Continuing on in GI, we look next at malrotations and malformations. Malrotation is just what it sounds like. Something is twisted, and a volvus is when something twists on itself and gets pinched off. These are very serious. The intestines should be movable. They're held together by the mesenteric membrane, but they're not. They have a lot of movement to them. They're not stiff and rigid, and they can twist around and get entangled, especially along the main artery through there. They can get twisted, and that's when you can get a part that's pinched off. It's no longer getting blood supply to it, and you can have some necrotic bowel as a result of that. So malrotations and volvus are very serious. Imperforate anus, this is when the anal sphincter doesn't develop. This is why we take that first rectal temp when a baby is born, just to be sure that the anus is there and it's all intact. This takes surgery to correct, and depending on how much of the intestine is missing, the large intestine, sometimes they can create an anal sphincter, which is usually one surgery, and they have to make a colostomy somewhere for the stool to get out. They'll let that sphincter surgery heal and then connect, reanastomose the intestine to it, as long as there's enough intestine. Sometimes there's not enough, and then it becomes a much more complicated surgery because they're creating tissue in there. Cloacal exstrophy. I've seen this a couple times at Children's. It's pretty rare. This is externalization of the bladder, and often can include the bowel outside of the abdominal wall. So sort of like the gastroschisis is the intestines outside, the cloacal exstrophy is your bladder and or bowels. Usually this involves the genitalia as well, that it either is indefinite of whether this is male or female, or it's just it becomes abnormal as well. It's involved in the anomaly. Celiac disease. This is kids who can't digest gluten, which is wheat. So what they have, the proximal small intestine has abnormal mucosa, and it has a permanent intolerance to gluten. So this doesn't get better and worse. It's kind of a immune problem. Their body reacts to the gluten, and then the intestine gets very irritated because of the reaction it's having. Gluten is primarily in wheat. When you break down wheat, it's also in barley, rye, and oats. So these kids are not absorbing the nutrients, so their failure to thrive. They also will have chronic diarrhea because they've got this irritation going on. We need to give them a gluten-free diet. They can have rice and they can have corn, so that things can be made out of rice flour or cornmeal. They can have no hydrolyzed vegetable proteins, and they may need a lactose-free diet, but usually that's temporary, just while everything's irritated until it's healed. Then they usually can tolerate lactose. And here's what happens. The wheat, rye, oats, barley make the gluten, then they have the reaction to it. These toxins damage the epithelial cells that are the lining of the intestines. That causes malabsorption of basically everything, of fats, which make really nasty, fatty, foul-smelling stools, blocks or interferes with the absorption of proteins and carbohydrates, which causes nutritional problems. It blocks absorption of your vitamin D and calcium, so that has bone as well as muscle problems. Vitamin D, which causes blood coagulation problems, and your iron, folic acid, vitamin Bs, which lead you to anemia. So those are the problems that we end up seeing. These kids are malnourished, failure to thrive, anemic. If you looked at bone density, it probably wouldn't be good. They may have a little bit of a prolonged clotting time, and that's all from not tolerating the gluten. And if we just get them on the right diet, they do very well. Carnitine deficiency. I don't believe this is in your book, but you will see this a little bit at children, so I've got a slide in here. Carnitine, this is needed to transport your long-chain fats into the cell's mitochondria, which is where energy is stored. So if you don't have it, you see failure to thrive. It can be taken PO or IV, and it's usually, you'll see it listed as L-carnitine or levocarnitine. And they use this in most conditions where there's muscle wasting, anything where they need to help build muscle and improve muscle energy, muscle use, muscle tone. So you will see this given quite a bit at children's. And then we can also check for carnitine deficiency and give it if we find an actual verified carnitine deficiency. Short bowel syndrome. These are kids who have normally lost bowel because of NEC from prematurity. So they've surgically had to have the necrotic portion of their bowel removed. They're left with too little bowel is basically what their problem is. So they have malabsorption resulting from decreased mucosal surface area. They don't have enough intestine to absorb what they need. It can be from congenital anomalies, NEC, as I said, that's what we see most of the time at children's. A volvulus, so they did have something twist and die and it had to be taken out, and now they don't have enough intestine left. Or radiation, if they've had a lot of their gut irradiated because of a cancer. They are TPN dependent. They cannot absorb what they need through the gut, so we give them TPN to supplement their nutrition. We also want to give them enteral feeds, though, by putting very easy to digest formulas, things where the proteins are already broken down into small pieces. By giving that, we encourage as much absorption as can happen through the gut. So typically these kids will have a G tube, at least an NG, but usually a G tube, and we'll put them on continuous feeds at night and let them eat normally by mouth during the day, but we want to really maximize the amount that they are able to absorb through their gut. And the reason for that, by stimulating the gut to work, we actually increase the height and the absorption area of the mucosa, the villi, the villus of the mucosa in the gut. So with less they can get more. They still cannot get enough to live, though. They've got to be on TPN to get enough calories, nutrients to grow. And being on TPN long term, that destroys your liver. Our bodies are made to have it absorbed through the gut, already broken down to very small pieces, not put straight into the bloodstream, where the liver has to do all the breaking down. So these kids end up with liver problems. There is starting to be some possibilities of transplant of intestines, because that's really their main problem, is they don't have enough intestines. But if they stay on TPN long term, they need a liver transplant down the road. Life expectancy for these kids really varies. It depends on how much intestine they have. Most of the ones we see who are in the hospital frequently at children's don't have very much intestine, and their life expectancy is not really very good. And here's a little girl who has a Broviac catheter, and probably for TPN for some reason or another, possibly short bowel. And we use a different dressing now. We don't use a gauze dressing. We use tegaderm so that you can see the insertion site.